did under HCBS services. And as you all may know, a lot of the things we did there was to ensure payments for our providers so that the safety net remained. It included some additional flexibility so that they could continue to serve our members and they could continue to receive services. We have what's called 1135 waivers. Those are waivers where CMS has the discretion to exercise sort of blanket waivers to the states for some flexibilities that were implemented. That's where we were able to, for example, change the platforms in which telehealth could be delivered, because otherwise they were, very stringent. But with the 1135 flexibility we currently have in place, we were able to open up access for telehealth on various platforms. That also allowed us some flexibilities around provider enrollment. Just anything we could do to reduce the administrative burdens to providers so that they could be directing their attention to care. So that included the 5-year renewal that providers have to do that's required under federal law. So it relaxed that. Those are currently on hold. And it relaxed some of the licensure requirements, so we allowed for alternative settings. A provider already licensed in another setting and was in the process of licensing a separate setting, we were allowed to allow services at that location. So those were some of the flexibilities under the 1135. And then some additional flexibilities as the PowerPoint slide references. It included a lot of things for our nursing facilities, including extending to a 30-day bed hold from 14 days, increasing the reimbursement for bed reserves to 75%. So we took some additional actions under those flexibilities. So for the public health emergency unwinding, we have 3 primary goals. One is to stay compliant with CMS requirements, very important. The second is to prevent unnecessary administrative terminations. So we want to make sure that people who have to go through an active enrollment, they have additional information that we need so we can verify their eligibility. We want to make sure that we're helping them through that process so they don't get terminated when they're actually eligible. And third, we really want to make sure that we can transition those people that we have determined are no longer eligible to other coverage, so like the qualified health plans on the exchange. So we want to be able to make sure people understand what their options are and help them smoothly transition to those to that other coverage. So this, I know, is a bit overwhelming, but that's because this is a very, very complex process. So we wanted to kind of throw it all at you and just show at a high level, and again, I know you all have this, but just at a high level what that timeline would look like if we started to unwind. This reflects an anticipation of a public health emergency through January. So if that's the case, we would receive that 60-day notice in November. We receive that notice, and that will then kick off, or we will switch our system to restart those redeterminations. So in November, the system will start working through those then who would be renewed in, if January is when the PHE ends, then renewals, the first month that we could terminate somebody for being ineligible would be February. So this just contemplates what you all can see, that there's been a lot of work going on that continues up until that 60-day notice. So right now we are still, our system changes are pretty much all done. Like they're ready. We just need to flip the switch when we get the notice. What we've been working on in addition to that is communication. We want to make sure that we're working with all the stakeholders, and that's advocacy groups, that's our MCOs, members. We want to make sure we have a very comprehensive communication strategy so that we're keeping everybody informed about what's going on, but that it's to the extent that we can do it, to make it less complicated, simple, understood, a message that's understandable, and that we give to everybody, so everybody knows exactly what to do during this period of time. So that communication strategy is still being developed, and we are in the process of meeting with various stakeholder groups to make sure that we understand what they need, the population they work with, and so we can tailor that message and that communication to fit that. There's another slide that kind of goes in to look like what that renewal process really looks like, but this is the work that's going on right now to get us to that point in February.
And I'll add that another thing that's already prepared and ready to go, waiting that 60-day notification.
Yeah.
Is,
Start that again. Thank you.
Another thing that's prepared and ready to go is training for DCBS field staff. We have a training that is prepared. Once we receive the 60-day notification, it'll be made available to those staff to give them just-in-time training to basically be prepared to do work they haven't done since before the pandemic. So, and along with that, other resources and things they may need that'll be helpful. We work with program specialists in the field, get their input on that so that we can have those things ready as well.
I do want to make sure you understand that once the PHE ends, on that date, our flexibilities end, except for Appendix K. For those HCBS flexibilities, they extend 6 months beyond the PHE end, which we're grateful for because that gives us time, a little more time to unwind those flexibilities and keep those members, as you understand, they're definitely some of our most vulnerable members. That'll give us more time to unwind those flexibilities for them. So what are we doing to prepare for the renewal? CMS has issued guidance. We've had several state health official letters. There's been webinars. There's a regular monthly meeting with all the states. We have a one-on-one meeting with CMS to go through how are we prepared and what are we doing and what's it look like and what do we need. They want to make sure that we understand what all the flexibilities are that we can utilize for unwinding, because there's additional flexibilities available to states. We are reviewing every single one of those to see, are they applicable to Kentucky? Is it something that we need to utilize? We're trying to be very thoughtful and intentional about whether or not it's something that will benefit us, and if so, then we're implementing it. So there's a lot there. It's a very long spreadsheet of what those flexibilities are, and they come under various buckets and authorities under CMS. So we're just, again, making sure we're doing our due diligence on what those are and what can we do. We've been doing a lot of internal review. So our team has been meeting regularly. All of our agencies, our sister agencies, so the Department for Community-Based Services, the Office of Application Technology Services Systems, which is OATS, our sister agency that does that helps us with our IT. So we're all meeting together regularly to make sure we understand what's going on with the unwinding, and do we have everything covered as part of it, as part of our initiative to do that. We are, again, looking at that renewal process and making sure that we have every piece of that, the communication to the member, the resources available. We are going to have to rely on not only DCBS workers, but our connectors and others to help us make sure that member understands what's happening, especially if it's an active renewal. And I'll talk a little bit about that in a minute. But we just want to make sure people have access, our members have access to the resources they need to get through that redetermination process. So again, working very closely with our advocacy organizations, our managed care organizations, which they're gonna play a big role in this. We've been doing a lot of that work behind the scenes. And then again, preparing our communication strategy and making sure our system is ready and able and working properly to ensure those redeterminations are correct. So this is the Medicaid, a very simple, high level of the Medicaid renewal process. What happens is we do everybody who would be subject to that renewal in a month. So not our entire 1.6 million people, but that's broken up over. It'll be broken up over 12 months. So the renewal gets processed. So everybody goes through this process. And then what happens is there are people that can be what's called passively renewed. That means we have enough information, we're able to go out and ping the federal hub. We can verify income, we can verify everything. And so they can be determined renewed. And so that's a passive renewal. They'll get a notice of renewal and they're done. It's the active renewal, so that top workflow that we're most focused on. So those who have to be actively renewed means that there's something we could not verify. So we will send out a letter to them. We will let them know what it is that we need. And then, they have to take the action to submit that information to us. There are various ways they can do that. They can do it on their mobile phone. They can get online to connect. They can go to Connect or our Dcbs local office. So there are various ways that they can work through whatever it is that we need. And then once we receive that information, we can make a determination. And after that, if they're still not determined, we still can't determine eligibility, or we've determined they are ineligible, then they'll get a notice of that ineligibility. They can appeal that notice. So they do have appeal rights. We are trying to be very flexible on the length of time they can appeal. So we're giving them 120 days to appeal. They can, come back if they get that letter. They can come back and just ask for us to take another look at that without a formal appeal. So we're giving them every opportunity to make sure that they can, demonstrate to us that they are eligible. If they don't return any information to us, if we get no response at all, then it does go on to a notice of denial. And again, they'll get appeal rights. But it's really that top workflow that we're going to be focused on, and it's that top workflow of individuals going through that we're going to work with our advocacy organizations, with connectors, with Dcbs workers. We're going to have our managed care organizations reach out to their members, because they, are often communicating with them more than we are directly. And we're going to communicate with providers and ask providers and make sure they understand how can they help this individual that's come into their office. Especially if they look up in Kentucky Health Net, which shows our eligibility, and it shows they just became ineligible, that's a great conversation for a provider to ask somebody, did you just go through the unwinding? Did you just, lose your eligibility, and refer them over to a connector? So we're hoping like all hands on deck approach to making sure that our members have access to the information and the resources they need through this process. So this just takes, we get that notice in November, and this breaks down a little bit into more detail of what that process looks like for someone. So this presumes that we've got that November 12th 60-day notice. Our system then is going to, in December, automatically start processing those February renewals. That's in the background. They're gonna go ahead and the system's gonna look through those people that would be subject to a February renewal date. In January, the active renewals will get that the passive renewals will get that notice of renewal. There's nothing else they need to do. The active renewals will get that letter saying what it is that we need from them. And then in January, the March renewals will start processing in the background. So then come February, if by the end of the month we do not receive the information, or we've received the information and we've made a determination of what that looks like, whether or not they're ineligible. If they're not, then they'll get issued either that notice of renewal or the notice of termination or denial. And again, they can appeal from that. And then in February, April renewals will start processing, and March renewals will start receiving that active and passive renewal letter. So that's just a kind of a snapshot of what it would look like come November 12th, PHE end notice. So this is a snapshot as of September 1st. I do want to say that this is constantly changing because our system is constantly processing those renewals in the background now. It's doing it, and we're not doing anything about them, but it's allowing us to at least get a sense or an idea of what that population is that might become subject to, that may be ineligible either due to income or some other reason. So we've been, our system's been able to give us that, but it changes every month because it just depends on when somebody's come on and we've done that background processing, and even maybe somebody who's been in this bucket of potentially might lose eligibility. Maybe the next month we're able to identify the information that we need, and we've been able to verify it. So that bucket of the estimated total to lose eligibility, which it shows 210,000, that changes every month for us. So this is just a snapshot. We did, as part of that snapshot, we can kind of dig down into what we can see as the income that's on there. And what we see is that about 75,000 or over the 138% FPL, which is the top of what you are Medicaid eligible. We can see that their income would qualify them for at least a qualified health plan with an advanced premium tax credit, a PTC. So that, again, this 75,000 people could move over to a QHP plan, and they could have access to tax credit to make that more affordable to them. We've broken down this snapshot of what the age group looks like, and as you can see, 25% of them are 18 and under. That concerns us, and we're definitely interested in making sure that those folks, that the determination we make for them is accurate, because we certainly don't want to lose somebody who may actually be eligible for Medicaid. And we're going to, again, focus on those individuals to make sure that if they do qualify and can move over to a qualified health plan, for example, that we're taking those actions to help with that. This is what the caseload looks like by month right now. Again, this is a snapshot as of today, as of September 1st. A caseload means a case. So these are not individuals. These are cases, and the case can have maybe 2 people in it, could have 4 people in it. It just depends. It's based on household. So these are the cases that if we were to unwind right now, this is what our caseload would look like for our DCBS workers and our connectors. Keep in mind that this is total caseload. We think that maybe 75% of these cases would probably passively renew. So that's what we're looking at right now. So obviously our priorities are making sure we have an unwinding plan, which we do, and that we're able to communicate that plan with CMS. we're going to have to, once we get that notice, we're going to have to provide them a baseline and a monthly report so they can see, they want to know how the states are doing with their caseload work. So we'll be doing that. We're doing stakeholder engagement, making sure all the system updates are ready to go. Still making decisions again about the flexibility, still combing through those to make sure that we're taking advantage of all those that would make it, the best process for our members. And just lots of coordination across our sister agency. And training. Training I think is going to be critical, and make sure especially people understand, our DCBS workers and our connectors understand that, maybe helping somebody move to a qualified health plan if they're ineligible, helping them understand what they can do to get that information to us, upload that information, or to report that information to us. Now, there's 3 slides that talks about all of the integrated eligibility and enrollment system changes. So IEES is the system that does all this processing I've been talking about. It's an amazing system because, as it notes, it's integrated. It has most all of our benefit programs in it, so our SNAP, TANF, so we're able to show we can determine eligibility across all those programs for our members. So that's the system that the changes will have to be made in. What we again have been doing is we took a look at everything we did to the system to start PHE, and now we've put into place everything that we need to do to unwind that. We have changed, I'm going to touch on a couple of things. I'm not going to go through them all, but we have changed for our automatic re-enrollment into a managed care organization to 120 days. We did that because that allows, if somebody drops off and they go through an appeal, or we can get their information and get them redetermined, they're not going through the problem of getting a new MCO assigned to them. They can go back to their old MCO. So I think that's something that's important for continuity for someone. If they had an MCO, that's probably the MCO they want. We didn't want that to become a barrier to them, through that redetermination process. So that is one thing that we took into account. Again, we extended the time frame for administrative hearings to 120 days to give everyone enough opportunity to provide that information. And of course, that's really critical for those who are in Eastern Kentucky and the disaster zone, finding the information that the documentation we might need. They need that time. It definitely takes that into account, I think. A couple of things here. So what we've been doing every month is what's called a special circumstance for these folks that fall into the probably likely ineligible. That's called a special circumstance. So every month we've just been moving them over to keep their eligibility. We'll stop that process come the PHE. So that'll stop. We've been creating the template that we have to do the reporting to CMS. So the system has to be able to do that. That can't be a manual effort. It needs to be something that can come out of the system automatically. So we've been doing that. And outreach. So, we have been trying right now we don't want to put fear and anxiety unnecessarily out there. So what we've just been trying to do is just tell people to update your contact information because, first of all, the unwinding, the PHE end date has changed so many times. So that's, a critical piece to that. We don't want to go out there and tell everybody you're about to be renewed when you're not. And it goes over 12 months. So when somebody gets renewed, that's, going to be different depending on when the end date comes. So we've been trying to make sure that people understand right now, just keep your information updated. But once the PHE ends, we will want them to know it's really important to check your mail at that point, because there's going to be that critical letter in there that says we need something from you, and that ties to your eligibility. So that's the time when people really are going to have to pay attention to the mail. One of the flexibilities we're utilizing is for managed care organizations to be able to utilize their information to update mailing addresses. Right now, we're allowed to do that, but we have to then go back and verify that information, which is a bit redundant because the MCO has that new information. And so for them to be able to share it with us and we can consume it and then move forward and utilize that, it is often almost 99.9% of the time the most current information for that member. So us being able to utilize that information is helpful. The other thing we're doing is we've implemented a new system change that allows that if we get mail back, returned mail, it will automatically check that. Because the Postal Service notice is on there, it'll check that, it'll automatically update our system, and then we can resend the notice. That's a huge new innovation for our system. That's a major manual, very labor-intense process to have somebody sit there and look at returned mail and change the system. So to be able to automate that, I think is very helpful. We are, we're, again, because the IES has the SNAP eligibility too, that's helpful. We can check both those, all that information to determine the Medicaid eligibility along with that, as long as it's verified. So there's, again, I did not go into all of them, but there's a bunch of system changes that have to be taken into account. So very high level, lots of information. Tried not to get too much in the weeds because it is complicated. I could probably be here for days to talk about all this.
We don't want to do that, so thank you very much, Commissioner and Assistant Director. So I guess the short of it is we do know we have at least 200,000 people right now who are on Medicaid who are ineligible or would be ineligible once this process starts.
It's the potential right now, yeah.
And how did you derive that number? Is that because I noticed some of the previous slides that you had something about preparing an algorithm that would,
right,
I guess, focus in on where
that's right.
those cases were.
That's correct.
So,
yes,
so where is that process, and how does that affect the 200,000 number that we're looking at in the presentation?
It's that algorithm that has helped us identify those people. And I just want to emphasize potential because it's just what our system is seeing right now in terms of their, for instance, let's say we've gone and pinged the federal hub and we can see what their income is. And so it's showing that they may be above income. But until we send out that notice, and they go through an actual renewal process, we don't fully know. So that it just, again, identifies, it has all the rules of eligibility, it runs it in the background, and this is the kind of the bucket as of September 1 that is potentially not eligible.
Okay. Thank you, Co-Chair Meredith. You're recognized.
Thank you, Chair. And Veronica, thank you for your presentation. You always do an excellent job. Really appreciate it.
Thank you.
Got 2 questions for you, possibly 3. This looks like a Herculean effort. I'm sure you're overwhelmed. I'm overwhelmed by it. You identify these inefficiencies are going to be a problem, but what other obstacles to success do you envision? And it's not a leading question, but I'm concerned that do you have enough resources to effectively do this?
I think we have to be honest to say that we're concerned about that as well. We're doing our best to make sure that we're retaining and recruiting. I think, and I'm not here to speak on behalf of DCBS, but I think we've had a vacancy issue in the last I'd say probably 6 months due to efforts of the commissioner for DCBS on increasing salaries. I know our cost of living or our increase on July 1 was extremely helpful in retaining and recruiting. That's been the thing. But, you know, as we bring them on, they have to be trained. So even if we can increase our workforce during this time, you know, we still have the training piece.
Yeah, I would agree with that. I'm sorry. I agree with that. The staff turnover and staff retention are a part of this as well. And so we're just trying to address that as we have been over the last couple of years. I think the staff raises absolutely have helped. I think staff morale is on the rise, so I think that's a positive.
And I will say that the CMS has given states some flexibility on how to allocate the population across the 12 months, and that's helpful to us. And we can also then create a case mix each month that isn't as overwhelming, because, you know, some cases take more effort than others. And so that's going to be helpful to us. So we have some tools available, but I think we're going to stay concerned about, you know, do we have enough folks on the ground that can help process the renewals?
I know this is coming very, very quickly, and possibly, co-chair, we may need you to have come back in November to kind of give us a state of the nation address as to where we are with this, because we can't afford to fail on this. But I appreciate your efforts today. The 200,000, again, not holding you to that number. We understand that's kind of flexibility, but if that's a true number, does that get us back to pre-COVID numbers in terms of eligibility?
No, we're still going to be about 100,000 more. That's, you know, that's growth in Medicaid, I think,
Sure.
2.5 years. So I think that's probably fairly within the trend. So we'll still have new folks we've gained over that period of time that are eligible.
My last question is not to blindside you, but and we may need to talk about this next month, but kind of prepare you for it, is the Court of Appeals decision regarding Anthem's participation in the MCO program. I'm not sure whether you all have had time to analyze that, to review it, but you got a gut reaction to that? Because is it going to create chaos within the system? And if it is, how are we going to deal with that?
A couple of things with that. First of all, it remands it to the circuit court. So circuit court has to take action, and they still have the opportunity to appeal. So while we are reviewing it and looking through, you know, what are we going to do next if it ends up happening, right now that appeal time is still running, and so we're not taking any action until that happens. Our contract with Anthem, we put a provision in there for this specific situation, and that is to allow a transition time so that we can make sure that we are thoughtfully transitioning those members. And it's not abrupt. It's not going to happen the day that order gets issued. It's going to happen over a 3-month period. So we'll have the ability to notify members. We can give them they'll always have the option, even if we assign an MCO, they always have the option to choose a new MCO. That choice is always available to a member. It's required by federal law. So we do have a plan in place for when this was going to happen if it happened. We're just waiting for that period of time to expire before taking any action.
Well, as slow as the judiciary process is from time to time, I mean, we could literally run this up to the next contract renewal period.
It's possible.
And I would assume that probably we're developing RFP to release sometime in 2023. I think we would have to. I'm not sure what your timeline is for that, but is that a fair assessment?
I can't really speak to that.
Okay.
But the contract does end in 2024.
That's December 31st, 2024.
Mm-hmm.
So again, I would think just backing it up, and that's the math I'm going from, backing it up, that we'd have to do this in earnest sometime in 2023. And so I'm sure we'll have additional dialogue with that. But again, thank you for the presentation. You've both done an excellent job, and appreciate you being here this morning. But I think we do need to have you back.
Okay.
Thank you, Mr. Chairman, and Veronica, thank you for the presentation. I want to make sure that I understand the timeline of this. So if the health emergency is lifted in November, then 3 months later, these folks that are the extended Medicaid population, the match from the federal government would stop at 3 months?
So a couple of things just to make sure it's clear. The notice will come in November for the PHE to end in January. We have, if that's the case, let's say it does happen in January, we have the 6.2 FMAP, the additional FMAP, enhanced FMAP through the first quarter. So we'll have that additional funding, that percentage through the first quarter is the way that works. So it's quarter pure.
Okay, so it covers that population. While the appeal is taking place, are they covered during that 120-day period?
They can ask for their services to continue. That's correct.
Okay, and then that would also be covered under the federal match.
That's
during
correct.
that appeal period.
Absolutely. Yep.
Okay, and staff get a lot of complaints. I've had some not so good experience getting through on the phone. Are the staff that you're going to need to do that going to be back in the office at that point?
I don't. Do you know the answer to that?
Staff are, as of this week, staff are back in the office.
Okay.
Yeah, at least a hybrid, all staff at least 3 days a week.
Okay. And just one final, Mr. Chair, if I might. Are you all getting pretty strong hints that November is going to be the end?
No. They're really keeping it guarded. It's really hard to know. It's really hard to know. I think we probably will likely know towards the end of next month if it's not going to extend beyond January.
And do you all have a running kind of tab, I guess, on what this extended population, as far as state dollars that it has cost through the federal health emergency?
I'm sure we do, but I don't have that with me today. Happy to get it for you.
Okay, thank you. Thank you, Mr. Chairman.
Senator Alvarado.
Thank you, Mr. Chairman. And Commissioner, I appreciate your guys' presentations, thorough. I have a few questions. On this PHE, is this a federal requirement for us to participate in this? Because I mean, the wording in the slides was that it's permissive for states to do this. Is the federal government requiring us to have all these flexibilities and to have this extension?
Yes, so yes, the federal CMS has required us to handle it this way. For the 6.2%. FMAP, however, the enhanced FMAP, that's where the continuous coverage is required. But I will tell you that, CMS has, I think, pretty much given us the belief that it's still expected
So,
to do it.
I mean, in your first slide, it says the PHA allowed states several flexibilities.
Oh,
So I mean, are these things?
Yep.
I mean, that's what I'm wondering is, okay, if we're going to say we have to have this expanded Medicaid, is this a federal
Mm-hmm.
order saying you must extend all of these benefits to all these people to this level, and states you have to do it?
So the flexibilities, though, are different. States did not have to implement every flexibility, and there are flexibilities we did not take advantage of, and of course I cannot think of them at the top of my head. But what that language meant to convey is that CMS issued all these flexibilities, the ones that I showed you, the Appendix K, the 1135s, and then there are some emergency state plan amendments that we could have implemented. States weren't required to implement all of those. States had the flexibility to say, I want this one and I want that one for other pieces to this. So that's what is.
So what are they requiring us to do then? I guess that's because the
Sure.
reason I've got the question is this is a cost to the state. 200,000 more people every month. What's a premium's around $600 per person. It's about $120 million a month just to have them on Medicaid. Not to mention all the other things that we're expanding this for. There's a cost to the taxpayers of Kentucky for this. And if the federal government's saying you have to do this, that's a federal mandate saying Kentucky taxpayers, you will pay for this. this legislature has ended the state of emergency this past legislative session. We've said there is no longer a public health emergency. And if the feds are saying, well, we think there is, even though I think all of us agree that there isn't, at least the legislature does, it's a cost on us. I'd like to know that. How much is that costing taxpayers to comply with a federal mandate for an emergency that this legislature doesn't think actually exists anymore? That's a concern for me. We've got, 100,000+ job openings in the state. And if we're saying, hey, even when we come out of this, 100,000 more people that are going to be on it, when we have that many, at least, job openings out there, those are major concerns I've got. I mean, and I'd like to know exactly what the feds are saying you have to do as a state, or if a lot of this is permissive, because if it's permissive, I think we've decided this no longer exists. We should be making that transition now and not wait until the feds give us or allow us to make it and say, well, all the things that we're requiring from you or that you were permitting from you have to go away. That's something I think we need to know, because I think, again, the slides I was seeing was like a lot of this is we're being allowed to do these things. I don't know that we need to do them anymore. We've already made a determination from that as a state that we don't think this actually exists. So that's one thing I'd like to know. If you can delineate what the feds are making us do and what they're saying you have to do, and that Kentucky taxpayers are going to have to front 70% or 80% or whatever it is of that price tag, because they're not covering it all for us. If they were giving us, saying, here's all the money, you're going to expand it, fine, okay, then we can say, we'll take it, I suppose. But I suspect they're not doing that. They're making us pay a lot of that. And if it's a choice from us or from the executive branch saying, well, we think we need to do this, we've already made a determination that that no longer exists. That's a concern for me. The other one is this. I've gotten a lot of emails from folks that when they lost their jobs during the pandemic were automatically enrolled into Medicaid for coverage for health care. And then they've gotten other jobs during this time. They'd never signed up for Medicaid, are not accustomed to government kind of involvement with their health care or anything else. And when they got the new job, did not know that they had to disenroll from Medicaid. And now we're getting bills saying you owe us $6,000, $7,000, $10,000 for the premiums that you've accumulated over the last year because you were getting Medicaid coverage and you got another job and you have this as well. And a lot of people are saying, well, they were enrolled in both. And they said, well, I didn't sign up for the first. I lost my job and it was kind of part of the whole pandemic. I got my job. I'm concerned that's going to happen here, that a lot of folks, as they get disenrolled, will have other jobs. And then they're going to get a bill from the state government saying, you owe us for paid premiums in the past because we were paying it for you and you didn't tell us you got a new job. And they didn't know because they never asked to be signed up to begin with. I don't know if you can address that issue.
So what I'd like to do, and perhaps it's coming back next month or sending you a communication to really delineate through the lens that you've asked, which is what's mandated and what's not, because I don't want to misspeak to that. But for the other issue you talked about, nobody automatically gets enrolled into Medicaid. You have to file an application. I think what you're talking about is when somebody is on the qualified, because we don't have premiums, but the health exchange does. So if they were enrolled in a qualified health plan and they had premiums and then may have been dually somehow enrolled in Medicaid, I do know that there were a handful of situations where that happened, and people can request to not pay back that premium for any conflict between those two programs. If somebody has gone out and has gotten employed during this period of time and their income has increased, which again is potentially that $210,000 bucket, 210,000 person bucket, and maybe they're accessing coverage through something else, like their employer coverage. We require third-party liability, so that information, and we go out and we find that. If they don't report it to us, we find it and we put it on there. So I will say that within this bucket are people that have third-party liability, and so they are primary and we're secondary. So we're definitely making sure that if there's other coverage, that coverage is utilized first, before Medicaid incurs any expenses.
I know it's not that situation. There is a per member cost that we pay for Medicaid recipients to our MCOs, correct?
That's
there
correct.
is. Yeah.
Yes.
So that's what he was referring to. Is
okay.
the person who had a job. It wasn't a premium. What we pay
I'm sorry.
to the MCOs
Okay.
through Medicaid is a per member cost per
capitation
month.
payment.
Yes.
Okay.
So that was what he was
Apologies.
being charged back. He had a job. He
Gotcha.
lost his job. He qualified for Medicaid, received Medicaid, got a new job within a matter of months, 6 months, had a new job during the pandemic, was getting that. did not know to disenroll, and then was getting a charge saying, here is what you owe the state of Kentucky for what we paid for your health insurance. That's happened. I've got emails and I've sent them on. So there's people that are being charged for that issue. So that's the concern that I've got, is as we start to disenroll 200,000 people, many of these are not going to know. They're going to be, naive to how government works and how this stuff works. And all of a sudden they're going to get stuck with potential bills or saying, you owe us money. That's my fear, because it's happened to people that I've received. And I have forwarded those emails to you all to review, to say, well, he's required to do this. And the guy says, look, never applied for Medicaid in my life. I've always worked. I've always provided for myself. Now I have to rely on government. And now you're charging me for something that I had no idea about. That's a worry with 200,000 people coming off the service. But the true concerns I've got is cost per month for this state. Is it federally required? What are they? If we have to participate in this, if it's a federal requirement, fine. What if not? We should be disenrolling that stuff now, because we've already made that determination as a General Assembly. Thank you, Mr. Chairman.
Representative Wilder.
Thank you, Mr. Chairman. Thank you for the presentation. This is really daunting, what you guys are facing. Actually, Senator Meredith asked my workforce capacity question already, so thank you for that response. If I'm a Medicaid recipient, am I aware that this unrolling is coming?
Again, we've been a little hesitant to send out communications directly to members to talk about you're going to be subject to renewal, because we want to do that for the month that they're going to be renewed.
Right.
But we have been communicating with them through various text and email and other communication that this is going to happen, and that's our campaign with make sure your contact information is updated. Right. And we've also been working very closely with the advocacy organizations and with the different community-based organizations that are out there working with members to make sure that they are aware and they are helping those individuals understand what's about to happen.
Thank you. Quick follow-up, if I may. Once we start hearing from our constituents, and I expect that we will, I've been kicked off my Medicaid, I've lost my Medicaid, how can we best help, and how can we direct them to get the assistance that they need?
I think connectors and the DCBS local offices, and I know what I'm saying, because our call center can get overwhelmed, and they could get overwhelmed, but those are the best resources. The other thing is, if there's somebody that if they don't have the ability to access the internet and they're Connect, because every Medicaid member can access their account on Connect, our system. Maybe somebody can help them access it to see what is going on with their eligibility. Maybe there is a piece that's missing, or maybe if they have received the the notice of denial, perhaps they can help them with an appeal during that time. You're welcome.
Representative Prenti.
Thank you, Mr. Chairman. Senator Carroll asked one of my questions, but this is a lot of work for what ifs. If it's not definitely in January, can this work be just automatically moved forward?
Yes, that's what we've been doing basically, is because this is, I don't know, like the 5th or 6th extension. Okay. Probably maybe more than that, but we just, we continue to sort of put the system changes on hold. Again, they're waiting for us to flip the switch. For us, the additional time is helpful. One is to make sure we have enough staff to handle it, our call center and our application processors and connectors, and they're trained. And that gives us more time to communicate with stakeholders to make sure that we're really focusing on the populations. We just met with some folks around maternal and child health who are advocating on behalf of pregnant women and children, and it was very helpful for us to get their perspective, because now we can maybe have additional resources of outlets of communication that we didn't have before. So we just continue to keep working on that to make sure that we're prepared.
Well, I'd like to echo Senator Alvarado's. If we don't have to be doing this, I'd say move forward with it, hopefully in January. But anyway, thank you, Mr. Chairman.
Senator Higdon.
Thank you, Mr. Chairman, and you certainly have a daunting task with 1/3 of Kentuckians on Medicaid. That's a big task, and I know the MCOs and the cabinet depend a lot on electronic communication with a lot of these recipients, and out in the real world, they're not all connected, and even those that are connected to the internet, they're not computer savvy. They just don't understand a lot of them. So that adds to your complication. But I guess my question is, I've heard rumors before, and I've asked this question about, Kentucky was one of the original expanded Medicaid states, and we had always heard rumors that there were out-of-state folks that crossed. We have a lot of borders with other states that are not participating, that we had out-of-state folks somehow come up with a Kentucky address so they could participate in Medicaid. So, and I'm sure as you go through this 1/3 of Kentuckians, that is something that's verified that you look for.
Yes, absolutely. We verify addresses. I think the other thing that I always like to remind folks is that it's our providers who deliver services to these individuals. They're the ones seeing them in the office. They're the ones providing services to them. And that's, I think, another conduit in terms of, as I mentioned earlier, making sure our providers know and understand what's going on as well. We do often hear when they check eligibility and there's eligibility issues and retro terminations and that comes from our system and our due diligence to make sure that it is a person in Medicaid that's being covered and they're eligible. And sometimes that takes time to verify. And again, we may be sending people notice of denial that are truly eligible, but because we didn't get any information from them, we can't make that determination. So, the process, I think, is about as good as we can get in terms of verifying that somebody is truly eligible for Kentucky Medicaid.
And I'm sure you're using all your resources, because there is a lot of cross-referencing now with computers.
Yes.
And Kentucky has an excellent system, and you said you're checking with on the national level too with them. So
we do.
Hopefully, if we have somebody that's participating illegally, that we can stop that. Thank you.
Absolutely. Well, and our IES is very robust, and we are utilizing other databases such as unemployment, and there's a whole host of databases that we utilize.
Well, thank you very much. We appreciate your presentation. Oh, I'm sorry. I forgot my co-chairman. He had another follow.
Oh, sure.
It's all right. It happens all the time, mostly at home. But
I haven't had enough coffee.
I appreciate it. Just very quickly, we've had some discussion about personnel needs, and glad to hear that the actions we took last session will help improve that. I don't know that any of us are at the point that we've tilted the table back to where it needs to be yet, and again, that is a major concern with your presentation today. But I'm just curious as to whether the recent change in the telecommute policy has had any impact on the personnel in your all's areas.
I can say from the Department for Medicaid Services perspective, telecommuting has allowed us to recruit and retain a lot of folks. But the return to work policy, we've been working with our staff on how best to roll that out, and trying to keep in mind their specific situation and be as flexible as we can with that, including what days they come into the office, flexible hours. It is what it is. We're just dealing with it.
Well, I think that's what concerns me, that it is what it is. I'm not sure that it is what it is. And I think all of us are getting just tons of emails from concerned employees, and it looks like a one situation fits all, and it doesn't. And I could see, particularly for Medicaid, where working at home could be a very productive venture for folks. And if you're used to doing that for the last year or 2 years, and now that's being disrupted, I'm not sure that's in the best interest of anyone. And I just encourage people to, again, take a hard look at that policy and make sure it's more cabinet or division specific rather than just a broad-based statement policy that here's what we're going to do.
Yeah.
The flexibility that you're given, that's great, but I guess we're not yielding on you got to have 3 days in office and 2 days that you can work from home. I think there's got to be some additional flexibility in that, but again, I'm concerned about the turnover it's going to cause within your areas, and appreciate if you can keep us informed of how that's coming.
Absolutely. I do know that there has been some changes, for example, for our cabinet based on the building itself. There's been an extension until January at least for us to return to 3 days. So they've given us some discretion and flexibility with our employees, and even again with the return to 3 days. I mean, I think we had some flexibility around that. So we're just trying to work within, the parameters.
Well, we don't live in a bubble. We being state government, and we're in competition with the private sector for these
Yes.
same employees. And
Yes.
if they're allowing them to have that flexibility and can truly be productive, and I think we're remiss if we don't take a look at that and make sure that we're being creating a competitive work environment for them. But thank you, Mr. Chair.
Thank you, Senator Carroll.
Just quickly, Mr. Chairman, and I agree with Senator Meredith to a point. Customer service jobs need to be done in the office, and that's my experience. What I'm hearing, that's just not working at all. But my question is, and we've got the Personnel Cabinet coming this afternoon to testify on the telecommuting, and help me understand. And my understanding is that the Personnel Cabinet makes these decisions, and then it's pretty much across the board, and whatever latitude you all get comes from them. Is that correct?
I honestly can't answer that question. I'm sorry. I mean, that's my understanding is the Personnel Cabinet makes the rules and we implement. But how that process works, I'm not familiar with.
Okay. All right. Thank you. Thank you, Mr. Chairman.
Thank you. So is that decision made by the Secretary of the Cabinet? Is that of the Personnel Cabinet?
I'm not familiar with how the Personnel Cabinet operates.
Okay. Well, you had mentioned they,
Yeah.
so I was just trying to figure out who they
They,
were.
they
who
meaning the
are.
Personnel Cabinet.
Okay. Okay. Thank you. Well, thank you for your presentation.
You're welcome.
And our next presenters will be on Medicaid managed care organizations' efforts to improve health outcomes, network adequacy, and access to care, and that will be Passport Health. And if you'd come forward and introduce yourselves for the record, and then you can proceed. Please proceed. Introduce yourselves, please.
Good morning. My name is Ryan Sadler. I'm the plan president and CEO of Passport Health Plan by Molina Healthcare, RYANSADLER.
Good morning, Nicole Basham, Vice President for Network and Operations for Passport by Molina. Nicole NICOLEBASHAM.
And I'm David Hanna. Am I on?
I don't think so. Should be green.
Oh, I thought it was lit.
There you go.
I'm David Hanna. I'm a clinical psychologist and the Director of Behavioral Health for Passport.
Very good, Mr. Chairman and committee members. Thanks a lot for having us here, inviting us back to speak. We'll have got a number of agenda items here to walk through. And then I want to make sure we start with a remember the member. And this is something that we challenge our team to do. I just think it's important. We talk so much about the business of Medicaid, but it's important to remember that we're taking care of these patients in a third of Kentucky, really. This is a story about Linda. She's a member of ours, and she's in her 20s. She's got 3 children. She suffers from bipolar disorder and has historically had challenges taking her medications. This is a real life experience that just happened a couple months ago. In transition of a inpatient stay, she was assigned to transition of care coach, Kara, who's an employee of Molina. And our job, right, is to manage her services after an event to help make sure that she's got access to services and care that she needs to avoid going back into the hospital or to another admission. It's to make sure that her transition is as successful as possible. Again, this is not a front-end healthcare service, right? It's about that sort of wraparound care to make sure that the patient and members are taken care of. So in the process of this, Kara understood that Linda has been having a number of manic episodes. She's lost her children. She's lost her job. Her father has requested a mental inquest warrant, essentially to get CPS to take care of the kids in the interim. So as part of this process, our staff working with her and her providers were able to get her access to Abilify, her drug therapy, in order to help manage this condition. This is a real life scenario, right? So Linda she's apprehensive about taking medication. She's apprehensive about an injection. And for me or you, maybe that's not such a big deal. But for her, it's the difference of her getting her children. It's the difference of her getting her job. And so our staff's able to kind of hold her hand, coach her, talk through the process, and eventually get her comfortable with having an injection. Not only that, but through the process, eventually coming to terms that, in fact, maintaining some sort of compliance with her drug therapy is what's going to make the difference of her being able to manage her family and her challenge with bipolar disorder. So, long story in the end, this is just a good example of where we're able to coach her through the process of being able to take her medication and therapy, ultimately resulting in a good outcome in this scenario where she's getting custody of her children and regaining her job. Now, this is not really a Molina story per se. It's really a managed care story. And I say that because all of us do similar types of services and offerings to make sure that we're taking care of our members and hopefully avoiding unnecessary care, which would have been certainly another inpatient admission. So, in any case, it's helpful to remember that we're focused. Our job, the whole purpose of our being, is to make sure that we're taking care of our members. Just a couple comments here. I think you've seen most of this, but I just wanted to comment on a couple things here. One, the word hospital in the bottom right is a little bit of a misnomer. It's more like facilities than I'd say hospitals. But we have a little over 700 employees, and that's important for a couple of reasons. But mainly, the main point I want to make sure you guys know is that we're hiring. Molina is hiring. We're hiring hundreds of additional folks. You may have seen some of this. I'll make sure that you get the notices of our job fairs that we're doing. But in particular, a number of our folks can work remote. And as a result, it's a great opportunity, particularly for our folks in rural Kentucky, that now have an opportunity to work for our organization that maybe didn't have that opportunity before. So I want to make sure that our people outside of Louisville appreciate the opportunity here to work for the managed care companies, and in particular, Molina. Finally, just a little snapshot so you know a little bit about where we are. As you see, some 68% of our membership is in and around Region 3, and in particular the greater Louisville area. I think, as you know, this has been a historical footprint for Passport. And then, really where we're trying to go is our commitment to the Commonwealth to get outside of Louisville and grow further out into the more rural parts of the state. I just want to comment that I personally have an obligation and feel a sense of commitment to get out of Louisville, not because there's any ill will with Louisville, but the fact of the matter is we provide excellent service to our folks in Louisville. And I expect that every person in this Commonwealth deserves the same access to the services that we provide, whether they be in Louisville or East or West Kentucky. So we'll run through the agenda questions just as the other MCOs have done. And I'll turn it over now to Nicole, who handles all of our network and operations.
And apparently I handed it to you, so I apologize.
Take it away.
Thank you, Ryan. As Ryan said, I'm the Vice President for Network and Operations, and we appreciate the opportunity to be here and talk to you today a little bit about what we do every day in the trenches. Network adequacy is one of the top priorities for our plan. And since we purchased Passport and began implementation on Molina systems in 2020, our philosophy is around securing our network. Around securing our network has been to secure a dynamic network that provides quality care for our members. It's really important that we focus on the quality of care for the members that we have. To successfully achieve this, we must keep a few principles in mind that I have my staff in the back of their mind every day as they work. The network has to be broad and serve the diverse population that we have in this state, both from rural and urban settings. The relationship with providers must go beyond securing a signature on a contract. It's really important that we don't just get the signature to the contract and move on from there. We must be aware of the needs of our members, and we must rapidly address any gaps in service that we see for our members. Having acquired Passport's network, which was mature, we offered providers the opportunity to just convert their contracts to Molina paper. Any credentialed provider is welcome in our network. We don't have any restrictions other than you have to be credentialed to participate. Molina actively analyzes every indicator which highlights any potential gap or opportunity that we may have to enhance our network. The graphic you see on the right of the PowerPoint is just an abbreviated outline of the ongoing monitoring activities that we do. These are just a few of the levers that we pull every month. And again, there's some frequency to them, so they get pulled at different intervals, but these are just a few of the levers. I'm gonna just highlight just a few of them. The first one is looking at provider out-of-network treatment, single case agreements. Looking at both of those helps us determine whether, again, there's a potential gap in service for a particular area, or whether we need to help a member get, redirected to another service. In any event, it again gives us an opportunity to ask the questions, can we partner with these providers to become part of our network? We look at geo-access reports, which plots members and providers across our state to see, it gives a pretty evident picture of where there could potentially be gaps. And then the last one I'll point out is our CAP survey. Again, there's many levers, but I wanted to point out the CAP survey because that's a member satisfaction survey around provider appointment times and provider interactions with members and their satisfaction with that. On our last CAP survey, Passport achieved an overall star rating of 4.5. What I'll say is, nobody really wants to show your warts, but the bottom line is utilizing these members helps us identify the gaps. And just for an example, last month in Region 8, because of some of these levers, we were able to identify a gap for oral surgeons in Bell County and addictionology APRNs in Floyd and Pike, both of which we've been able to address by going out and getting new contracts for providers in those areas that hadn't before been a challenge for us. What I'll say to you is these levers are not unique to Molina. I'm not up here telling you anything about some secret sauce that Molina has. Every MCO uses these levers and should, in some version, to identify gaps. I believe what is unique to Passport and what sets us apart is our engagement of a team we've stood up called a Concierge Team, which is out there to remove barriers for both providers and members when special needs arise. We had a situation with a member who needed a stretcher to be transported. As you know, during the COVID period, staffing, just like the cabinet and everybody else, staffing was a concern for all of us, as it is for our partners. And so they had a staffing shortage, which meant a scheduling issue for getting non-emergent transportation for this particular member to their treatment. Very significant, important treatment, non-emergent, obviously. And so our concierge team was able to do all the coordination, and I call it the dance. They did the dance to make sure this member got to their appointment, and that's the specialized treatment this team does to overcome those types of barriers and make sure. And again, then we have to go look and see how else can we support them. So we've handled this instance, but then what do we do in the long term? And that's the piece that continues to be a part of our conversations. Our goal is to ensure that our network is dynamic and that Passport continues to be flexible. This is no longer a cookie cutter business. We have to be flexible and nimble about what our providers need and about what our members need. So, as I said earlier, it can't just be about the ink on the paper for providers and gaining a network access and checking the box that we're sufficient. Our approach to network adequacy isn't limited to a partnership in the traditional sense. It's not enough to contract with a provider. We've got to continue to maintain these relationships. We focus on delivering the basics. We want to make sure payments are prompt, that we're doing direct and supplemental payments, that we're submitting encounters properly so our FQHCs and RHCs can get their RAP payments, and addressing issues as they come up. I'd like to say everybody's perfect, but it just isn't the case. Issues are going to arise. The difference, I think, for us, and for us, you know, as it relates to some of our peers, is our ability to rectify that in a timely manner with continued communication with the providers. Having a 6-day average, you know, claims receipt to payment helps us foster a quick financial impact to our providers. We actually have partnered with other MCOs to participate in joint RAP meetings so that we can collaborate for a more streamlined solution for these RAP payments for FQHCs and RHCs. I think we all understand that's been a challenge for a while for the state, and I was previously at another MCO. It's not new news. We just have to get a better solution at the end of the day for those. This year, Passport by Molina has implemented a PCP-focused performance-based agreement. We implemented models, including some shared savings models, which are heavily geared towards providers meeting quality and HEDIS needs. With our goal of 77% of our membership being, pretty aggressive goal, 77% of our membership being included in tied to one of these agreements by the end of 22. The agreements we already have in place, which today covers about 51% of our membership, is already seeing some improvements around medication adherence. And I think in the world of COVID, that's a pretty spectacular improvement, again, and that's about the partnership between us and the providers with those agreements. These models are most specifically important to our rural communities. Our partnership with KPCA, which I'm sure you're all familiar with, it ensures the inclusion of key FQHCs, rural clinics, dental schools, and then other school-based providers with KPCA. It offers a performance-based model with the goal of encouraging and preventing wellness and preventative activities, improving outcomes, and managing costs. It incorporates education programs for both our providers and members. We engage as a partner, data analysis and data sharing in support of better outcomes. We offer this KPCA example. It is just an example, but the performance strategy is foundational to Passport's provider experience. And again, we're in the very early stages of the execution. We're excited to see where these are going. And finally, I will mention our one-stop shops. We have 6 across the Commonwealth: Lexington, Covington, Louisville, Owensboro, Bowling Green, and Hazard. Dr. Hannah will provide more insight into these centers, but briefly, our one-stop centers serve to augment the rural communities by offering us a host of resources, both for members and providers. These are not specific to just member abilities. And then lastly, these facilities are staffed by members from the local community. So we're hiring in the community that these facilities are. And then last, kind of the last component to supporting our network and to supporting our members is our relationships with community organizations. I know we may be running a little short on time, so I'll just briefly talk about, you know, we've chosen to engage with these organizations because of their diligent work in the communities, their goal and a mission that's aligned with us to address social determinants of health and food, such as food insecurities and rural health challenges. Our partnerships go beyond a financial contribution. It's important to Ryan, as he's, you know, shared with all of us in leadership, that we must contribute not only our time and talent in addition to the dollars. You know, we have to be at the table with solutions. And when we don't have solutions, we've got to be at the table developing them with our partners. So saying all of that, even with all of the work that I've got my staff doing on a daily basis, you know, we acknowledge that even though we have a strong network, that we still have challenges across the state, especially in our rural areas, around physicians or provider shortages in oral surgeons, dental, and behavioral health. We continue to try to solve for those issues. It's going to take all of us, you know, probably all the MCOs at the table, to work together to address these shortages in the rural communities. And, you know, Passport continues to seek additional innovative ideas with our partners in support of this growth. It's important to all of us. I will now turn it over to Dr. Hannah.
And just point of clarification, Dr. Hanna is our Director of Behavioral Health Services, and so is responsible for that side of the house at the plan.
Okay, are we doing okay on time? Do I need to go fast?
I think so. Defer to the chair.
I
Okay,
think
all
you're
right.
okay.
I think we're okay.
So the next question that you asked were what specific initiatives are we undertaking to improve the health of the Medicaid population in Kentucky? I want to talk about two things: our community outreach team, community engagement team, our specialized care management programs. Education is sort of a basic building block for improving people's health. And we deliver health information at things like health fairs and similar activities across the state. But in addition to that, we conduct member-specific health education classes that address things like diet, exercise, and disease management in person, and then we offer those on a daily basis virtually. They're offered in both English and Spanish. And Nicole's already mentioned our one-stop health centers to make services more accessible. We have information there where people can learn more about their health coverage, government services, community resources. But we also are helping people with job applications and job opportunities. We provide free computers and Wi-Fi access to our members. We have meeting space for members, and each of those centers has full telehealth capability. And then Nicole touched on our local investment. We have a number of relationships with organizations, the International Center in Bowling Green. There are programs in really across the state, NAMI and Kentucky Refugee Ministries, Catholic Charities, and so on, that we work with in partnership to address needs, mostly around things like food insecurity, housing, and other concrete needs that people have. And then we have specialized care management programs. And these are programs where we reach out to members with our clinical staff with people who have identified needs that increase the health risk for them. And we do things like we identify people who are using the emergency department a lot and outreach them to see if we can help get them connected with appropriate care. And we have what we call models of care. These are where case managers with specialized training in things like high-risk pregnancy or severe mental illness, where they can, reach out to people with special resources to help them in managing their condition. And to give you just one example, and we can move that forward. I don't have the mouse here, but of what we've been able to do with using both our community-based staff and our clinical programs, we have been quite successful in seeing the number of Medicaid members get their COVID vaccinations. We currently are number one among the health plans based on Medicaid's numbers of eligible members for vaccination. And so you can see that we're that on the slide, and we're using similar kinds of tools to address other health needs across the state.
If I could just interrupt real quick, that number's actually just gotten over 47%. So I'm actually excited to see there's ongoing uptick, despite the fact that we are well removed from the sort of heightened sense of urgency for vaccines. But it's something we continue to pound on because we do think it's important, and it's not gone from us yet.
Okay, so the next thing you ask about were what tools are utilized to measure the effectiveness and efficacy of substance use treatment programs that we contract with. I'm excited to talk to you about this because I've implemented outcomes management systems before, and I think it's important to know. There's three major ways that we look at outcome information. And first of all, there's data analytics, where we use the large amounts of information that we get from providers and our members to identify patterns that indicate the outcomes we're achieving. I suspect that all of you have heard substance use treatment providers tell you that if for people who complete their treatment program, 70 to 80% remain sober at 3 months or 6 months, whatever their numbers are. But the real challenge with substance use treatment is getting people to complete a program. It is, the reality is that on average, 14% of our members leave within 3 days of starting substance use treatment. And only 25% who start make it to 2 weeks. But as I said, this is an average. In fact, when we look at our data, we see some providers doing an excellent job of engaging members in treatment, and others are struggling in that area. And we are able to use that to help direct people to places where they have a better chance of being engaged in treatment. And across all the SUD services we cover, we use things like lengths of stay, whether individuals are stepping down to lower levels of care as they complete more intense treatment, whether or not they're returning for the same treatment service right after discharge, to monitor the effectiveness of the services we cover. And second, there's utilization management. Now, I worked for a community mental health center for nearly 30 years. And before I came to work for a managed care company, I thought that the only purpose of was to limit services in an attempt to limit the dollars spent. But I thought that because I didn't actually know what was being done inside a managed care company. Our staff are in-house at Molina and fully integrated with our clinical team. And because we only conduct utilization management on the most intense services, has become an important tool for identifying members who are not benefiting from routine levels of care. And furthermore, utilization management requires providers to do an assessment, identify a clinical plan, and be accountable for obtaining outcomes according to that plan. And I know this is a pain point for a lot of people, but a sound function gives us a direct line of sight on the quality of care that our members are receiving. And third, there's provider and member relationships. It's harder to quantify this, but we really try, and you heard Nicole talk about this, to maintain a close connection with providers. I and our provider services staff spend time every week talking to people who deliver services. I often provide consultation around clinical issues, and I also consult with people about what the experience of working with a health plan is like and how to be successful with that. Knowing providers gives direct information on the quality of the work that's being done. And similarly, our case management staff and our community engagement staff talk to our members and about their experiences with treatment and treatment providers, and they share that. We share all that internally with each other to try to identify where is the best place for people to get care. And third, you ask, what are the strategies for ensuring equity in healthcare delivery? Equity refers to making sure that all of the members get equal benefit from our coverage and services, regardless of their personal characteristics. And I want to just mention 4 things that we do in this area: care connections, and I'm going to come back to that in just a moment. We have community connectors, most of whom are certified community health workers, and I'll just pause and say thank you for this last legislative session for recognizing the value that those individuals bring across Kentucky. And we have housing specialists, and the community connectors and housing specialists work to help members navigate the healthcare system and to meet needs like housing and food and transportation, things that are commonly referred to as the social determinants of health. We have on our staff peer support specialists. These are staff who have lived experience with substance use or mental illness. One of our peers said to me not too long ago, he said, "Dave, I've been sober for 13 years, but every single day it's a decision I have to make." And because they are a living embodiment of the reality of recovery, they can be especially effective at reaching members who are not currently engaged in treatment and helping people navigate their way into services and recovery. As COVID started to wind down and we started going back into the community, one of our peers, and sometimes when you're going to engage some of these members, they're not maybe the best places to go. And one of our peers said to me, she said, I will go anywhere because I know what it's like to be in a place where I couldn't get myself to a place where I could get help. And then we have data-driven, equity-focused quality initiatives. I've already talked a little bit about how we use data, and I'm just going to note that we can similarly look at personal characteristics of our members to identify whether or not we're getting equitable outcomes. As just one example, we have a project underway right now addressing diabetes care among individuals with substance use disorders, because we noticed that even though the members were getting connected with substance use treatment, there didn't seem to be the kinds of changes in their diabetes management that we would have expected when they got connected with care. And so we're focused on that. And we can go on to the next slide. I'm going to tell you a little bit more about our Care Connections program. This provides services in members' homes or other convenient locations to address gaps in care. Now, to be sure, our preference is always to connect people to local providers. But when that's not possible, this team can help fill in gaps. You can see that we have nurse practitioners located across the state from Owensboro and Litchfield to Ashland. And there's more information on the slide, but I just want to note that since January of this year, we've delivered over 6,200 services, including exams, well child visits, and hospital follow-ups to members in 118 of Kentucky's 120 counties. And finally, I just want to tell you about some of the success of our housing team. We have a team of 4 and soon to be 5 housing support specialists. They're handling about 75 housing referrals a month. In Louisville, where we have a large membership, we've developed a unique partnership with the local housing authority that has allowed us to use emergency housing vouchers to house 51 passport households. And we are now exploring how we can expand that model across the state. We're having some conversations down in Bowling Green, and we're excited about how that might move forward. And so thank you for your time, and I'll turn it back to Ryan.
Thanks. If it's all right, I'll just close briefly, and then happy to take any questions you may have. The first thing I wanted to mention relative to health equity is just I want to call out some of the great services that the MCOs have been doing, particularly around our disaster recovery efforts, and in particular, most recently in Eastern Kentucky. I want you to know you've got tremendous partners in your MCOs, and they are able to do a lot of things for this private-public partnership that the state may not be able to do. And so I've seen it now, unfortunately, a number of times just in the last couple of years here. But when bad things happen, your MCOs go to work, and it's not just Molina. I mean, it is a shared effort, and we're able to waive prior authorizations immediately. We're able to allow for emergency refills when people are losing medications. And we're calling and outreaching to folks that are taking that have refrigerated drug products because if they lost their power, then they may lose their drug product. We're able to deploy all sorts of resources, whether they be office supplies or just a helping hand. Not to mention our staff, the thousands of staff that work in managed care in the state are able to be deployed and go support folks, whether it's just cleaning up debris or whether it's filling out applications for FEMA support and the like. So I just want you to know that not only Molina, but all the MCOs are committed to doing their part to support this community and make sure that equity is connected. And finally, I'll mention it's not lost on us that we at Molina work for the administration, we work for the cabinet, we work for you. And it's an honor to be here at this table. It's a privilege, and it's not something that we take lightly. It's not always perfect, but I want you to know you've got a partner in us that you can trust to do the right thing and to take care of the members that we serve. And I hope we continue to earn that opportunity. So, and my last comment, just as a follow-up, Senator Meredith, we had spoken last week about an emergency room project that we're doing, and I wanted to give you a brief update on that. So 2 things. One is that this has been a collaborative process with the providers, with the department, and of course our own organization, trying to understand which claims and which services are emergent or non-emergent. And as we talked about, the focus is making sure that we're changing this systemic cultural habit of Medicaid patients consistently getting care in the ER, right? And so we've got to do something about that. And so one of the things that we're looking at in this process is how do we make sure that emergency rooms are reserved for emergency care? And so anyway, we're just going through that audit process now. And again, we're working collaboratively with the parties to try to figure out what is emergency care and what is not. The most recent part of that process is that the department asked us to put that on hold while we further investigate and regroup to figure out the right next steps. So I just wanted you to know that project is on hold until we figure out what the right next steps are. So that's it. Any questions? Happy to
Thank you
answer.
very much. We appreciate your time. Co-Chair Meredith.
Thank you, Co-Chair Elliott, and appreciate your presentation. As Mr. Sadler said, we had a conversation last week about this initiative. I'm glad to hear that you're putting it on hold, and we talked about doing a reboot on this. I don't think we can fairly say that it was a collaborative relationship in the beginning. And to bring everybody up to speed, I think there was a request for something between 16 and 20,000 reviews, retrospective reviews of ER visits, ED visits, and obviously that's concerning. Since I came to this committee, I've preached that I truly believe there's enough money in the healthcare delivery system in the United States to take care of man, woman, and child in this country. We spend it most effectively. And one of the issues that drives inefficiencies is the bureaucracy around healthcare. Presently, we're spending 16 cents of every dollar just on administration, double what other nations are doing. And this particular issue that you're talking about, if we're asking hospitals to retrospectively charge for 16 to 20,000 visits, that's a tremendous bureaucratic burden, particularly for small rural hospitals. And I don't understand why this can't be a concurrent review rather than a retrospective many months afterwards. And I think it's interesting that the letter that was sent out to providers came from Washington, D.C., the Cost Recovery Unit. I would think the more appropriate place it should come from is Utilization Review Group. Because, I mean, just the very title of that division, Cost Recovery, says we're going to take money back. And again, it concerns me that we're not doing this kind of concurrent review like other MCOs have put in place. And it's going to place a tremendous burden on providers to have to do this, particularly if they have to appeal those claims. So many months, possibly even years in retrospect, and that's just not a good process. So again, I appreciate your hearing our providers. I appreciate your hearing me, but it's those type of measures that concern me. I think I speak on behalf of everybody in this committee. We want a symbiotic relationship with our MCOs, and it's no secret that I have preached since I've been here. I think we have too many. I'll still yield to that, but if you folks are doing a good job, which should be measured by improving the health of our population, then we're going to see benefits from that. I don't think historically we have. I think we've gotten people's attention from the presentations we've heard during this interim session that we are doing things differently, but I think we're going to raise the bar just a little bit more. I appreciate you saying remember the member, but I think you guys also have remember the provider, because that's your partner. You don't deliver care, they do. And I don't think that anybody truly recognizes the disparity between urban healthcare and rural healthcare. Now, I know you got pockets in urban areas that are truly medical deserts, but it's even more pronounced in rural communities. And to say that one size fits all, it's never an appropriate assessment of the situation. There are unique situations in rural communities that keep us from improving the health of the population. Unless we're really willing to look at that, I don't know where we're going to move the bubble on this. Personally, I'd like to see more payment schemes based on some deprivation index that truly recognizes just not the number of providers in an area, but the other issues that we have. And I think it requires a partnership, because we talk about social determinants of health, but the bottom line is the poverty that exists in our state, both urban and rural. Unless we're willing to tackle that, acknowledge it first, but tackle it with the same fervor that we did with COVID, I don't think we're ever going to be improving the situation. But we want to see increasing accountability. I think there may need to be stronger measures for that, but I don't think that the 10-year history we've seen with our managed care organization truly supports that managed care has done a good job in Kentucky. Now, again, I see a renewed effort to try to do better, and I'm optimistic that we will, but we can't ignore the problems that continue to exist, particularly in our medical deserts, both urban and rural. Now, I'm curious, you made a comment about it, I think it was Region 8. You were able to bring some providers to the table you haven't previously. I'm curious how you did that, because, I think that the providers are there and they're hesitant to participate, as we particularly saw with dental services, is poor reimbursement. If you haven't seen an increase in 20 years, nobody's going to do that business. So how were you able to change that dynamic in that particular area?
Yeah, that's just one area that we were able to secure a provider in that region that we had not previously contracted with to be able to supplement that. I think your thoughts are spot on that we still have some work to do about being creative. We are currently looking at a mobile behavioral health services provider who can go around to some of the areas who don't have that in their region. But I think we have to continue those conversations about how do we get better at serving those areas, better telehealth, better internet so people can get telehealth. Our, one-stop shops are able to provide at least that, but then you have to, our concierge team will tell you, you got to make sure they can get there. You've got to make sure they feel comfortable coming there. And so I think we have a ways to go. We have plans to kind of change the landscape. I hear you. I've been in Medicaid for a long time, and there's been an evolution of change on focusing. In addition to providers, because I have network and ops, I've got kind of a unique perspective on I've got to get them contracted, I've got to keep them happy, and I've got to make sure the claims are paid. When the disaster hit in Eastern Kentucky and Western, frankly, both of them, my staff called every provider affected in those regions, every single one, and kept calling until we got a hold of somebody, not just because we wanted to make sure they were up and because we needed to tell our members if they had service, but how are you doing? What can we help you with? And as we went through, especially Eastern Kentucky, went through, Mountain Comp losing every piece of their facility. Yes, people needed, life-sustaining things, water and blankets and food. But you know what else they needed? They needed office supplies to be able to do charts on paper because the electronics were gone. They needed solar chargers for their phones. So because we have that relationship with them and we're able to call and say, what do you need? You're going to get, Red Cross is there and we've already sent water. I mean, day one, Ryan had people on the ground helping, try to establish what, the basic needs were. We went another step above and said, what else do you need? And we got many compliments back from providers saying, thanks for asking about me. And it's important to us that they are just as important. You're absolutely right. We don't deliver the clinician side of healthcare. But what I can do is provide support for them in the instances that they need it to get it executed.
And I think part of that support comes from, we've got to think outside the box. We can't do things the traditional way we've done it. Folks, mobile services are great, but it's not always timely. And from what I hear, one of the biggest issues that healthcare providers have is transportation for patients. In our current system, you got to have 72 hours notice before you can schedule something. Things change a lot in 72 hours. And is there a different way to do that? Is there a better way to do that? I think there is. Do we need like a Uber concept for that particular issue? But that's the kind of recommendations I would appreciate our MCOs would bring to our legislative committee. Says, we're trying to do a good job. Here's impediments. Here's what you folks can do.
Yeah, I think that makes perfect sense. I tried to implement an Uber at one point. We did a little bit of success in it, but it's not perfect, right? And so sometimes you have to try something, back up, review it, and see if there's something else. So happy to bring those additional recommendations back to committee.
Thank you, Mr. Chair.
Thank you, Representative Wilner.
Thank you, Mr. Chairman. Thank you for the presentation. And the news about housing support, that's news to me. I didn't realize that you guys were involved in that. We heard last year on the severe mental illness task force, we know that housing is such a tremendous issue for folks with SMI. And so I'm just curious what population you're serving with that particular part of your work.
Yeah, I'll tee it up and then turn it over to Dr. Hannah. So we have housing specialists that work for us, and that's their job. But I tell you, you cannot worry about your healthcare needs if you don't have a roof over your head, right? And so, again, this kind of goes to how we try to take care of the entire member, to make sure that they have the resources and environment in which they can actually focus on their healthcare needs. You want to talk a little bit more about what we've done? And by the way, I'm super proud of this because we have helped put a lot of people into in an environment where they can, for the first time in a while, have had a roof over their head.
Yes, I have to say, I'm not doing this in my current role, but last year, before I became the BH director, I actually sat in when we were reviewing the housing support referrals. And I've worked in publicly funded healthcare for 40 years. And I wouldn't have thought I was naive, but the housing crisis across the state is just astonishing to me. And we have really worked to for our staff to understand what that system is and how to help people get housed. And then we accept referrals on any member. This is not targeted only to people with a certain category of illness. If people have a housing need, they can get connected with a housing support specialist. And we're trying to work with community organizations to develop housing options. Now, we're not building housing, obviously, and in many places there are serious obstacles to finding something. But we have been successful, and you're always trying to figure out, are you tooting your own horn or are you like giving information? But when a lot of housing options became available, I think all of the MCOs were given an opportunity to get involved in that. But we stepped up with staff who would actually help work with the member to get through the housing process. And that's why we have this relationship with the Housing Authority in Louisville, because we've been willing to put people on the street to actually walk people through the process. And we want to work with other people in other parts of the state to develop that model so that we can help people get housing, because there's just no doubt that once people are housed, lots of problems go away. I mentioned earlier, we track emergency room usage closely, and there's lots of reasons why people don't use the emergency room appropriately, but one of those reasons is that it's cold outside and they're hungry. And I actually I can't remember where this happened, but sometime in the past year I was talking to somebody who didn't know what I did, and he told me how when he was homeless, how he would go to the emergency room to get warm. And I thought, oh, this is, it's what I'm seeing at work too. So yeah, we're proud of that.
Thank you for your presentations. I know we had some additional questions, but we do have one other presenter here, so we're going to conclude your presentation and thank you for your time and bring up our next presenter.
Thank you.
Thank y'all.
Thank you. So we have an update from the University of Kentucky Center of Excellence in Rural Health. And if that panel would come forward and introduce themselves.
First of all, good morning to the committee, and thank you for the invitation to come and talk about the Center of Excellence in Rural Health. I'm Dr. Fran Feltner, the director of the center, and I'll let my co-workers here introduce themselves.
My name is Mace Baker, and I'm the director of Kentucky Home Place, and its spelling on that is Macebaker.
Good morning or afternoon. Ernie Scott, I direct the Kentucky office of Rural Health at the UK Center.
Okay, I'm going to try to do two things at once here. So thank you again for the invitation to just come and talk about the center. And these were the questions that you gave me that you wanted me to talk about today. And as we go through the slides, I hope we can hit each and every point and then take questions that you might have for us. So we are the Center of Excellence in Rural Health. We are located in Hazard, Kentucky. We are also the federally designated Office of Rural Health, and we were established in 1990 to do the work that we do. The mission of the Center of Excellence in Rural Health is to improve the health and well-being of rural Kentuckians, and our vision is to have a healthier Kentucky. When you look at the map on the slide, we have around 170 employees that are also a combined total of the center and the North Fork Clinic that is located in our building for our employees that provide services in that region. Our programs there are academic programs, our State Office of Rural Health, Kentucky Home Place, which is our community health worker program. We also do research there to look at health disparities and workforce needs, and we are the host site for the UK North Fork Valley Clinic. I wanted to put the academic slide in here because if you have access to health, you need a provider. And our program, in cooperation with the colleges, with the University of Kentucky, has provided education for students close to home. And we have a total of 1,071 primary care providers working in the field. And out of these that have graduated, over 80% of them are still working in rural communities to provide services. As I said, we're also the State Office of Rural Health, where we work with Small Hospital Improvement Program, which we'll talk about toward the end of the slides here with your questions and try to give answers. Coordinate, educate, and inform providers through workshops and different vignettes. Looking at the long-term care goals that we have in order to improve the health of rural Kentuckians. The community health worker program today is a lot of the questions that were asked about. And I wanted to say that when Kentucky Home Place was first established by our legislators more than 26 years ago, the goal then was to provide access to services for the people in the communities. It was very important to hire community health workers from the community that they were going to serve so that they understood the community, they knew how to talk to the community, they were of that community and understood where people were coming from. Very important that they serve there. I think it's very important to note that we call them community health workers for a reason. They are of the community for the community. And as some of the language that we are hearing now in the bill that was passed, I don't want us to take the community out of community health workers. So that's what I'm going to talk about here. So we are located in Eastern Kentucky, and at one time, we were across the state. We were at the other end in West Kentucky. We were in Bowling Green, around that area. And because of funding cuts, we are at the only end of the state where Appalachian and Eastern Kentucky have the highest health disparities, have the highest levels of poverty, both in our adults and our children that live in Eastern Kentucky. We also, I wanted to bring a point that where we are located is where the floods hit so hard in Eastern Kentucky. Our community health workers were the first ones on the ground to assist people that were flooded. They needed many things and they couldn't wait for others to come. They needed their eyeglasses. When you go to sleep at night and you put your eyeglasses on your night table or your dentures or things like that that you need to do for daily living, when the waters came in so quickly, nobody thought, let's get our glasses, let's get this, let's get that. It's let's get out of the house so that we can survive. It was very rushed and very needed. Community health workers immediately went to the shelters to see who lost their medicine, to see who lost their wheelchair, who lost their medical equipment that they needed to be able to take care of themselves. And they did a great job doing that. They went in teams. I wanted to give you a review of like what it costs to have our program as far as how many people we serve, those kind of things, and the return on investment that we have in Kentucky Home Place. The question was that you gave me was how do we improve the health, particularly the Medicaid population. And if you look at the services there, just last year alone, $13 million was accessed in services and in medicine for the people that we serve. This next slide kind of breaks it out a little bit by, I'll get to that in just a second, but the role that they did in order to provide these services is to promote, maintain, and improve individual and community health, assist communities and individuals to adopt healthy behaviors. Community health workers are trained to find solutions to access social, medical, environmental related needs for rural Kentuckians and reducing those social determinants of health. Until you've lived with those social determinants of health, you really don't know how that affects a person and their ability to be healthy. Most important is that communication that is given between them to coordinate their care, between them and the provider. It might be that you tell them to take care of their diabetes, they're a new diabetic. They didn't hear anything you said except I'm going to lose my vision, I'm going to lose my feet, my kidneys, those kind of things. They didn't hear how important it was to manage their diabetes. So the other side of that is just to be an advocate for the person that they serve. And I do have to say that this is in person. During COVID, our CHWs had to adopt a way to be safely serving the people that they served. But until you can look into someone's eyes and help them with their needs, they don't necessarily walk into the doctor's office and say, hey, I don't have running water, I don't have food in my refrigerator, I don't have the things that I need for the basic needs of life, but they'll tell the community health worker what their needs are through an assessment. And most importantly, too, is that we collect that data. I look at that to see what the trends are and how we need to help the individuals and what the community needs are at that time. And again, I want to make sure that we don't take the community out of the community health worker and how important that is. So with the Medicaid clients, out of the 5,000 that we saw last year and that we served, over half of them were insured through Kentucky Medicaid. Kentucky Home Places services, more than half of the services were provided to Kentucky Medicaid members through Kentucky Home Place. $3.5 million in service value to our Kentucky Home Place clients. More than half of that was Kentucky Medicaid members. The time spent through coordination, the hours, more than half the hours were spent on Medicaid members. Kentucky Home Place provided over $9.9 million in medication values. Over half of that was with Kentucky Medicaid members. I just want to make sure that we receive referrals from all of the MCOs to do the work in the community as far as accessing the things that people need. I want to make sure that that is shown here, that over half the members receive that care. So I'm going to ask Mace here to talk a little bit about the training that we do.
So our training has been 25 years in the making, and it's evolving as the changes in healthcare come about. Not only do we train our internal folks, but we train people across the state with different agencies. So it was developed in consultation with health providers and experienced CHWs. So the center's role in training community health workers, we actually serve as one of the 2 Tier 1 community health worker training centers recognized by the State Office of Community Health Workers in Kentucky. It's us and ACAN. And like I mentioned, we train people with a lot of different agencies, health departments, MCOs, clinics will send community health workers to us for training. And once they complete our training, then they can apply for state certification. And then also, new to us, we're working on having external agencies come in and do the mentorship with our experienced community health workers. And some of our community health workers have been with the program over 25 years. We've got 2 that have been with the program 25 years. So there's a wealth of knowledge that they have to share. One tried to retire, and I'm not letting her. So, so our additional trainings there on our community health workers receive along with that is chronic disease self-management, training, and diabetes self-management, and that's through Self-Management Resource Center, used to be Stanford University. Mental health first aid training, suicide prevention, CPR, wellness recovery plan, tobacco cessation programs, and then they go through a lot of training with the Kentucky Prescription Assistance Program. And then lastly they all serve as connectors. So that's a big help when a lot of people, maybe they want to see that person in person to help with their insurance needs. They can come into our offices and work with somebody right there locally.
I do want to add to that, Mace, that during the time of the emergency sign-in for people, we serve those counties that I showed you on the map. But during the time of the emergency and people got emergency Medicaid, we also trained our community health workers to do that for the state. And they did not just keep it in that part of the state. Anyone that come across that system that needed that service, Home Place did provide that outside our service area due to the emergency.
And during that year, we worked remotely. During that year, actually, our services went up higher than the year previously. So they bumped up a little bit because there's a lot of different things that they were able to help people with that they're just not able to navigate. We helped with PE Medicaid, the pandemic food benefits, help with the census, help with just a lot of different things, stimulus payment. So things that I think Senator Carroll mentioned, that a lot of people aren't able to navigate these systems. So that's what our community health workers are there to help with.
Let me talk just a little bit about chronic disease self-management program. When they finish their training in this, they are certified lay leaders. That means they can conduct the classes for people in the community. And we get many referrals from the hospitals, the clinics, the health department, different folks to come in and do that. And they can be in classes of 6 to 12 people. And they come 6 weeks in a row. And most of the time we are able to provide like transportation costs for them to come and do those trainings. But it is in person. They get to almost learn from each other of how they manage their diseases. And particularly with diabetes self-management program, they are also certified lay leaders. They are able to help them make sure that they have the supplies that they need to take care of their diabetes, make sure they have their medicine that they need, make sure they understand about taking care of foot care, eye care, all those things that improve their health outcomes.
Yep, go to the next slide. Okay. So the center's role in training community health workers, another component that we're doing, we've taken this training that we did for health departments and things like that, we've taken it to the community college level. So we've had students that come over to the vocational school there in Hazard, and they go through this same training. It's just a little more drawn out, and we've actually had during the pandemic we had 2 graduates, and then most recently this year we've had 6 graduates of that program. And so I serve as adjunct faculty at the college, and as well as another person there at the center does.
I do want to make a note here too that it is the Kentucky Home Place curriculum that KCTS had adopted and got certified through the college system to be taught. So it is our Kentucky Home Place training that they use for that.
And this is a continuation of that slide. That's the name of the program, Students Striving Toward Better Health in Self and Community. And you can see our partners down there across the bottom, Home Place, the center, United Healthcare, the college, and then K-Tech. And so they receive, this is tuition free for the students. And once they complete that, then they can apply for the state certification for CHW. So we've actually got one that's came back last year and is working for us just right now, currently.
I do want to say the important thing about this project here is when I talk to some people about how we can improve the health in rural Kentucky, I said we have to start somewhere with our youth, to know if preventative services, to know prevention services, because their grandparents may have diabetes, their parents may have diabetes, for an example. But if we can teach our high school students how to manage diabetes, how to prevent diabetes, how to eat properly, how to exercise, those things that can improve their health, maybe this next generation won't be as sick. Maybe we can reverse, instead of kids dying before their parents do, maybe we can turn that around where our kids are living longer than their parents again. And it seems to be working. Some of the feedback I got from the students when they graduate was, we had no idea that we could prevent this or that we could do this, and how important it is to eat correctly, how important it is to, and when you look at poverty and how you can take advice about nutrition and how you can stretch those dollars to eat healthy, that's a challenge in itself. And I have many stories I could tell you there. We don't have the time today, but we'll move. This I'll talk just a little bit about. It kind of goes back to what we've been telling you about the bill that was put forward with the HB 525, the process of certification. Mace and I both have served on the curriculum committees. We've served on developing the programs with the cabinet. We've been members of that, the Community Health Worker state program now, as it's called, the State Office of Community Health Workers, to take the knowledge and skill that we have developed over the last 27 years to be able to not start from the beginning of things, to build upon what we know has worked and what may not work. I do have some concerns here in the bill as far as it is reimbursable to community health workers that are in the clinics or that are in the hospitals, those kind of things that will help with improving outcomes, that help the clinics improve their outcomes, their measures that they need to do. But if home place would not be considered in that because we are not a Medicaid provider. So the community and the community health workers are needed desperately, not just in the clinic. So that is one concern I have about the reimbursement. Where does that lie? And how do we get people still in the system to get them to the clinics, to get them to the places that they need to be without doing the direction that we do in home place? So I want to make sure that that's there. And I'll take any questions after this in a minute about that. At this time, I'd like for my director of the state office to talk about the SHIP program and refer to your handouts that were given to you.
All right. I want to thank you all for the opportunity to come and talk a little bit about our SHIP program, and that's our Small Rural Hospital Improvement Program. I think oftentimes some of the federal programs, we're too busy doing the work, and we don't really explain sort of what we're doing and what's out there. So I do appreciate the opportunity here. To sort of kick it off, I want to talk a little bit about the SHIP program in general. So there's an annual program that our office administers. It's funded through the Federal Office of Rural Health Policy, through HRSA, and it predates me. So it's been, this program's been funded for probably up to 20 years. And this provides small rural hospitals, 49 beds or less, with an allocation of funding that we allocate for each of the participating hospitals, and then they are reimbursed. So if we look back in the last round, there were 43 hospitals across the state. They each applied for and were granted around 10 grand for an investment of around $433,000. Doesn't sound like a lot of money, $10,000, but for these small rural hospitals, the way that they're using these investments is remarkable. We do work with those hospitals to look at approved expenses. On page 2 of document 1, there is a list of the hospitals that are currently participating. The allowable expenses, we can't do salaries, we can't do travel, so it's really into increasing operational effectiveness and quality at those smaller facilities. It breaks on down into what those investments look like on pages 3 and 4. So because we had this program in place when COVID hit, there was a mechanism in place to get these funds out to the rural hospitals. So when the Federal Office of Rural Health Policy received their allotment through the CARES Act, they said, so this is great, we have these funds, so how are we going to get those out to the hospitals that need them? And these hospitals were already contacting our office saying, we need help. I mean, we're already in bad shape, but now we're, censuses are going up, workforce is going down, we need help. So we were able to reach out to all eligible hospitals, those that were participating hospitals in the past, plus those that were had not participated in the program in previous years, and come up with 46 hospitals. So added about a dozen, 11 or 12 hospitals to the mix, and they each were able to be allotted around $73,000. Again, this was money that came through the university to our office, and we were able to push out immediately to the hospitals. So this was not something that took 6 months to a year to get to the hospitals. This was in a matter of weeks that the hospitals received these checks. Page 2 of document 2 lists those hospitals that were participating. That program has since closed, and I'm glad to say 100% of those funds were spent. So that there was none that were turned back. Those expenses were broken down. We had a menu of sorts, plus we could have some leverage to work with facilities to meet their immediate needs in the form of safety, response, and maintenance of operations. So those were brought down into 35% in safety, 42% in response, and 23% in maintenance of operations. Again, we had very little notice. If it hadn't been for our relationship with these hospitals, it would have been very difficult to get this money out in the time frame that we did. It went about a year later, and we received notice again in a expedited fashion in July of 21 that there was another pot of funds going to be released. And so we reached out once again to all eligible hospitals, those that had participated in the past and those that hadn't. And we came up with a list of 47. This was in about a week's time frame that we received commitment and interest and commitment from the hospitals to participate. Each hospital received around $250,000 that was sent out to them, again in an expedited fashion. It was prescriptive, so it was based, it was sort of limited to those areas of testing and mitigation. So no funds could be used for the purchase of vaccines because there were already so many other allocations that were going towards vaccine through vaccine hesitancy and such. We are finishing up that project right now. As of last quarter, 32% of the hospitals have fully expended those funds, and for an overall of 66% of the investment has been expended at this time, with the intent that all funds will be spent by the end of the calendar year. Again, these documents are here for a little better, deeper overview. I'm a man of limited words, and so I think Dr. Alvarado can attest to that. I'm quick and to the point, but so glad, though, to be able to share this program, and would love to share additional programs that we offer through our office. The collaboration that we have being situated in the Center for Rural Health is phenomenal. Many of the state offices of rural health across the nation are very isolated, and it may be 2 or 3 staff. We're able to do so much work because of the way that we're positioned in the university, and very appreciative of that.
I think we're at the end for questions.
Thank you very much. And I had one question about the workforce population of community health workers. Do we have enough of those? Too little? Is there still an ongoing need? Because I know that was a focus of this presentation. So
there is absolutely a need for more community health workers. And, we have poverty across our state. It broke my heart when I had to bring them from Western Kentucky, and we were all the way down in Paducah to that end, and had wonderful CHWs at that end of the state. We have about, some of our counties are really huge, and there's only one community health worker in that county. They do a phenomenal job, but it is a big burden on one to do. And if I had the funds, there'd be community health workers everywhere that work in the community to help the people like Home Place does. Never enough community health workers.
Thank you. Co-Chair Meredith.
Thank you for your presentation. And in the interest of time, I'm going to have to be very direct with you. It's going to sound very harsh. I don't mean it to be very critical, but in looking at when this office was established in 1991, I think your best responsibility being the voice for rural health care. I look at your website and what we do list, and I see a lot of programs that are certainly great programs, but they seem to be more reactive than proactive. And I would think if you're going to be the voice for rural health care, it needs to be the voice for rural health care. We talk about things like direct the coordination of efforts across the state to improve rural health. I've been here 6 years, and I don't know that we've ever talked about that before. Participate in statewide planning efforts and policy analysis specific to rural health. I don't know that I've ever seen any type of report on that. Act as a liaison between state and federal agencies. You've touched on that a little bit today regarding national rural health issues, but I haven't seen any recommendations as how to address those issues. Recommend actions to facilitate rural health program development and implementation. Again, I've never seen any report or recommendations to address that. Search for new ways to help recruit and retain high quality healthcare professionals in rural areas. What you folks are doing is certainly good, but it's not, shall I say, innovative. It's outside of the box. And I guess what I would expect is I want you folks to be more of a voice. If you're limited because of the lack of funds, and again, it does bother me a little bit because I'm from Western Kentucky, and I can tell you those healthcare deserts are as prominent there as they are in Eastern Kentucky. Absolutely. But we're not seeing anything. I was a hospital CEO for 40 years. Don't recall ever having any interaction with you folks. If you're going to be the voice for rural health care, you need to be the voice. And right now, I think at best you may be a whimper. And if that goes back to the lack of funds, then you need to advocate for more funds. I understand that we only allocate maybe $1 million over a 2-year period to this area, but if that's causing you to fail, I was strongly encouraged to be a much more stronger advocate and ask for more dollars, but in turn be able to show the return on the dollars. Again, you see the return on investment that you showed us earlier, that's great, but in 30 years, have we really improved the health of Kentucky? I don't think that we have. Have we addressed the manpower shortage in rural Kentucky? I don't think we have. Maybe we've touched on it, but I think we've got to be much more aggressive, progressive. When you're going to be the voice for rural health care, I look at your mission statement that makes aware of the needs of rural communities. Our committees on health and welfare, which many of us serve on, we've heard from various groups about here's things that have been laying here for 20, 30 years. I would really think those recommendations should be coming for you folks. You heard the presentation earlier about Eastern Kentucky and the lack of oral dental surgeries. We heard a presentation from those folks back there in the regular session, haven't seen an increase in 20, 30 years. I think if you all are going to be the voice of rural health, then you folks need to be coming to our Health and Welfare Committee and say, this is a problem that we're having with dental health. This is a problem we're having with all these services, and you folks are too quiet. I'm sorry, I don't mean to be overly critical, but again, I want you to be the voice for rural health.
I totally agree, and we do need to be here. Today's presentation was pretty much on the questions that you asked me. We do have the workforce studies documents on there that we do on the website. I don't know if you found those or not, that show what we need in the next 20 years exactly with our primary care providers, those kind of things. Those briefs are shared through the University of Kentucky and other colleges. The academic programs that I have at this center are based on what the University of Kentucky has to bring to rural. And I have advocated to bring public health. I have advocated to bring PA program, the nursing program, all kinds of things there. It does take dollars. Our tuition dollars that we get for the programs that are there are what we run the center with. Some of the things that you just read was through our federal programs, the missions of the federal program. With the center, education is a big part of that, the reason the center was put there. Our graduates from our residency program was another reason that the center was put there, to put medical providers in the community in rural. I feel like we have reached that. You can only graduate 4 of the residents a year through that program. So I hear what you're saying. I really do, but my hands are tied with funding. When it comes down to it, there's about $300,000 of state funding that comes to the center. The rest of that is tuition dollars and grants, and through those, about $15 million is grants. And actually, with those grants, we have to do what those outcome measures are called for in those grants, and a lot of those are federal grants. We do not have a lot of state money at the center, but I would welcome to come back and talk about what we could do with funding, how we could expand our programs that we do have, and I appreciate your candor.
Well, I would encourage you to do that and be much more assertive and aggressive with it. You know, another example I give is the nursing shortage.
Absolutely.
COVID kind of pushed it over the cliff, but it's been there for years.
It
and I would
has
think
been.
from your office, if you come to our legislative committees and say to us, this is a crisis, this has got to be fixed, and here's how we suggest doing it,
Yeah.
it's going to be a whole lot more to us than individual providers coming and saying, we got a problem, because everybody's got problems.
That's very true. And dental is huge. I mean, the dental issue that we have in Eastern Kentucky is huge, and I recognize that. We have worked with the College of Dentistry at the University of Kentucky to talk about that issue, about getting the providers to us. It is not one of the programs that I have at the center. There's 2 different sides of the center, too. There's the clinic side for the residency. That is a federal grant that comes through is an FQHC. That is not under my control as far as that goes. It is a way to give the poorest of the poor access to care because of the sliding fee scale. That is not my program. Bringing the academic programs, all I can do is say, here is the need to the university that we need this, and work with them to bring those programs to us. But, you know, the funds is a huge issue.
I appreciate that greatly, and appreciate you being here, appreciate your testimony. And
Senator Carroll.
Thank you, Mr. Chairman, and thank you all for what you do. What funds were lost that required you to pull out of Western Kentucky?
When Kentucky Home Place was first funded, it was funded at $1.9 million. We are now at $9 million, right at 9. I'm sorry, 900,000. I'm sorry, 1.9 million is what we had. 900,000 is what we have now, and that is reduced just about every year. We supplement that with grant funding that I can write a grant to do. For an example, the work that we're doing in the community now to give COVID vaccine and those things is a federal grant that I wrote to keep more of our community health workers. So each year that goes down. However, increases in salary goes up, benefits goes up, all those things, and I end up cutting community health workers. And I basically have cut administration to the bone because I feel like it's more important to have the CHW in the field than it is to have an administrator in the office.
Okay. Can you provide a proposal on what you all's needs would be to reopen that office?
Absolutely.
I mean, you're not going to get it if you don't ask. And knowing how important those services are, if I had been asked, I would have proposed that in the last budget. From what you're saying, it's not a huge amount, and it's very worthwhile.
The funding source changed too. We used to be a line item in the governor's office when Home Place was first created. That has been moved to public health. So our budget comes through the cabinet, through public health, is where that budget comes through.
Okay. I guess I just see the value of people at front doors and directly. I mean, to me, that's the key of figuring out what's wrong with our healthcare system, because we have all kinds of great programs. We hear MCOs every month come in here and talk about all the great stuff they're doing and all the innovative things that they're doing, but nothing changes. We're not getting any healthier. So, I mean, I think the answers are in the rural areas. That seems to be where we're struggling the most, and the types of services that you are providing, I think, are crucial to us moving that bar in the future. So I would ask that if you all could get some figures together on cost and what you might need out of the next budget to be able to open the Western Kentucky office.
I would be happy to do that.
Okay.
It would do my heart a world of good to bring them back.
Thank you, Mr. Chairman.
Thank you. I think that's all the questions we have, so thank you for your presentation. We appreciate your time today. And I wanted to also note that I think the passport Molina presentation was cut short, so if any member had a question they would like to submit in writing, they could do that to our staff, and then we would submit that to Molina and then disseminate that answer among the committee. So if there's no other business to come before the committee, the next meeting will be Thursday, October the 13th, 2022 at 10 a.m. So thank you so much, and committee stands adjourned.